Hello, everyone. Good evening, good morning, good afternoon, depending on where you are in the world. My name is Asonele Kotu. I just switched on my video for a brief moment so that you can meet me before we switch on to the presentation itself. But it's such an honor to be speaking to you this evening and to be able to have this conversation commemorating World Contraceptive Day, and such an amazing moment in our lifetime that we are able to have these conversations openly without it being stigmatized, and without conversations about being family planning being a private and a silent topic that we are not supposed or meant to be talking about in public. So without any further ado, as Stephanie introduced me, I'm the founder of FemConnect, and I'm based in Cape Town, South Africa. FemConnect is a startup organization that started in 2019, where we wanted to change the landscape around creating easy access to family planning, SRHR services, and specifically helping girls that are struggling with period poverty. And before we can continue with this presentation, I'd like us to take a moment and reflect in our own areas to look at what are the issues that we have noticed that are aiding issues into the issue around being able to access quality and equal family planning services. You might find that in many developed countries, you do not have those issues. But if you're looking at it from an African perspective, that is a problem that we face in our communities. It's a problem that young girls face in their journey of growth into womanhood. And it is something that we need to start providing solutions towards. We can move to the next slide. I see Joanna's hand is up. Joanna, do you want to say something before we move forward?
Real quick, I just want to hop in that we aren't unable to mute our attendees, but if you drop your question in the chat box, which is now live, we can definitely help you out, Joan. And for anyone else who has their hand raised, please just chat us in the chat box and we can help you out that way.
Okay, Stephanie, we can move to the next slide, please. So I'd like us to first start by looking at the population trends in Sub-Saharan Africa and in East Africa regions. And the reasoning why I specifically speak about Sub-Saharan Africa and East Africa regions is because it is regions that I'm familiar with in terms of the work that we do. These are regions that are starting to show quite a lot of innovation around sexual and reproductive health technologies. These are regions where you are seeing a lot of youth-led innovations coming up in the space of sexual and reproductive health care, e-health, menstrual health, and all these other issues that are supporting factors under the sexual and reproductive health umbrellas. And if we look in 2010, we had over 400 million people in the East and Southern Africa region. And it is estimated that in 2050, we might have doubled that amount to 944 million. And the reasoning behind this, as it's said by the UNFPA, is that we have more people living that are of reproductive age, which is coupled with changes around fertility rates and migration and so forth. However, the alarming statistic that is a constant reminder of where we might be heading to if we do not do something around providing easy access to sexual and reproductive healthcare services, specifically looking at contraceptive use, is the fact that in South Africa, between April 2020 up until March 2021, we have had more than 23,000 girls under the ages of 18 who gave birth. And in these 23,000 girls, you found that 934 of them were under the ages of 14. And in this group, 80% of them were between the ages of 9, 10, and 11. As compared to the 14,577 who were between the ages of 16 and 19. And you ask yourself, how is it possible these young children have experienced unintended pregnancies or have become mothers at such a young age? Where was the service? Where was the assistance? How did this happen? If I reflect back on the time of COVID, everything had closed down. We had a hard lockdown from March 2020, and the entire country was put on a strict lockdown where we couldn't, there were certain times where you can be outside and there's certain times where you have to be in. And we only had access to critical health services. So some of the health services were completely closed. For example, some family planning clinics that were within communities run by nonprofit organizations unfortunately had to close down due to maybe lack of funding, or maybe some of them were not seen as priority services at that point in time. We had that situation. The other issue was that many other young girls who are dependent on schools-based programs in terms of receiving educational information around their reproductive health and around their menstrual health were no longer going to school due to COVID, and therefore they could not get access to these youth programs that were within their schools or within their communities. The other issue was related to product stockouts, where local clinics were unable to access certain contraceptives because of supply issues, supply chain issues. So certain public clinics who provide free products were not able to maybe distribute pills to an X amount of people because at that particular time, the clinic had stockouts. So there were many other factors that exacerbated the issues of teenage pregnancy and increasing in the number of unwanted abortions, and also other supporting areas, other supporting things that would come with the risks that girls are exposed to during this period. If we can move to the next one, Steph. You can move to the next one, Stephanie. Thank you. So if we look back, so the problems, as I mentioned, have always been there. These, the one before. Stephanie, if you can please move to the one before.
Is this the slide you'd like to be on, Asonele?
Yes, yes. Okay. Thank you. My apologies for the laggy internet. We've got issues with load shedding at the moment. So yeah, as mentioned, the problems have always been there, and it was not just because COVID happened and then suddenly we had issues with girls, young girls and adolescents not being able to get access to services and contraceptives and so forth. The issues has always been around the fact that we've got overburdened health systems. And you find that specifically in South Africa, we have two types of accessibility to healthcare. There's the public healthcare route, which is subsidized by our governments, and that's where you can get access to free family planning services, free contraceptives and so forth. And then there's the private health area where you can get access to specialty services from gynecologists, or you can go to a private doctor, and then you'll be able to pick up your contraceptives through pharmacies and so forth. But that route is usually costly for people who do not have access to medical aid. The other issues is that there's been a lack of access to supportive structures or equitable HR education or organizations that can be able to provide advice or preventative measures or to guide young girls. And this is what you need to do. This is what you need to look out these are the types of activities that you should not be engaging in. There is a lack and a great need for such services because it is still regarded as a taboo topic, and it's still stigmatized for adults or adult women to be advising younger girls around contraceptive use or talks around family planning, as it's seen as a behavior or encouraging a certain kind of behavior. But I will go into depth as we go along the slides. Usually there's long waiting times in clinics, and sometimes that affects school attendance. Sometimes it affects the ability to get access to youth centers, as everything operates at specific time bases. And there's over 3.7 million girls who experience period poverty. They depended on school-based programs, which I mentioned earlier on, had closed down due to COVID. And there's a need for digital tools where educational content around menstrual health, SRHR, and family planning is the key topic, specifically for disempowered communities that are found in remote areas. If we can move on to the next one, please. Helen, what period poverty means, it's the inability or inaccessibility to sanitary pads. So you might find that girls that come from rural and disadvantaged communities, they might not have access to sanitary pads when they are on their periods, and how this affects them is that they either end up being at risk of being targeted by older men who are sugar daddies, and then they end up giving them money in exchange for sex and so forth. Thank you. So about us is we provide a digital platform, but we are an organization that is set on easing access to sexual and reproductive healthcare services within Sub-Saharan Africa and other African countries. We do this because we want to empower young women and older women with accessibility to telehealth services, period poverty, because we believe that we need to guide the young girl from when her journey in menstruation starts and usher her into supportive measures that we provide when she reaches an area of sexual maturation. And that is where we would then guide her with information to say, well, through our platform, you can speak to a family planning expert. You can get access to contraceptives. You can do this of her journey from the beginning, from the time that she experiences that she's on her period and she's able to make babies and reproduce. So our whole approach is for us to make the girl child understand that when you understand the process of your natural biology and reproduction, then you are prone, or you're most likely to make good decisions around protecting your. And that is a gap that we find in most African communities, because if I can speak for myself, I remember when I had my period, my aunt at that time who was with me, the only thing that she said to me, she said, be careful, don't be around boys. And that was the education that I got. The rest I picked up along the way. And this is the same for many people that were around me, my friends, my colleagues, people that were raised in the same community. We all had a problem where there was a gap where in our families or in our communities or in our cultures, where the part of where you have that conversation with an elderly person to make you understand that this is what's happening right now. And if you engage in any sexual activities, you are putting yourself at risk for this and this and this. And if you are doing that, this is how you protect yourself. But at that time, we did not have that. And you find that it's still a problem in various communities because we have not normalized speaking to young people around the issues around sexual and reproductive health, eliminating teenage pregnancy, trying to find ways of reducing the numbers of unwanted abortions and maternal deaths and so forth. So what we want to do as an organization is to be that supportive structure, but we want to do this through digital means, because like I said, there's a lot of stigma and taboo when it comes to issues around reproductive health and sexual health. You might go into a clinic and you meet an older lady that's a nurse, and this nurse can discriminate and judge you for wanting to start using contraceptives at the age of 16. And she might say something out that will make you feel as if you're doing something wrong. And these are some of the behaviors that chase young people from getting preventative education, because they feel that they will be judged and they will be stigmatized and they would be made to feel as if what they are doing is the greatest wrong thing on earth. So what we're trying to say is we are providing a user-friendly, a youth-friendly, and a platform that allows you to get access to what your body needs at your time, and then we bring it to your doorsteps without you going through all the hurdles and the barriers that we have seen happening time and time again in our communities. And we do this by creating communities of support through our beneficiary organizations that we work in. These are nonprofit organizations that are within the communities. We do this through online donations where people can be able to help young girls who do not have access to sanitary products, and they can donate to them, then we distribute to where the needs are. This also helps us to capture data around to where the needs are and to assess what are the information and educational needs that young girls have around sexual and reproductive health care. We also provide a website and a mobile app, because we've seen a lot of mobile app usage amongst young people. And for us, that is an easier way to connect with the youth and young audience in a personalized manner, because they will always have their phone with them. They will always be able to reach out, which makes it so much easier for them to be able to open up themselves in order to get the information and help themselves and help them manage their own lives. And we young women to family planning, online family planning service, online screening, in which in turn we would then do the facilitation of getting the contraceptives to them. So in a nutshell, that is what we do holistically. And that is how we approach the ease of access, or creating ease of access, in order to help reduce the number of teenage pregnancies, unwanted abortions, and so forth. If we can move to the next slide, please. So in the next slide, I'd like to take you through what is currently available and ways that we should actually, we can enhance what is currently available. And when I talk about the ways that we can enhance some of these ways that I'll be talking about, some other organizations are already starting to do work around the future of change status quo. For example, as mentioned, we have public clinics. That's where you get free access to contraceptives. And over 60% of women in Sub-Saharan Africa use contraceptions and family planning methods through the public health system. The public health system is then subsidized by the government. However, the type of contraceptives that are available through public clinics are limited. So in a public clinic, you'll get access to the pill, the UID, the Implanon, the depot injection, and you can have those are the options that are specifically for free in the public sector. And then in the private sector, there you can get a variety of different products. But however, the process into acquiring your family planning and your contraceptives in the private sector is different. You would first go to a doctor at a fee. The doctor will give you a prescription, for example, for 6 to 12 months. Then you go collect your contraceptives at maybe a pharmacy or at a different clinic on a monthly basis, and that's the process. The reason why the private route is a bit expensive is that for every interaction and for every engagement, there's a fee that you pay. And it's mostly people that are that have medical aids. And in some countries, they call it medical insurance. In South Africa, we call it medical aid. And in other African countries, they also call it medical aid. And this is a scheme where you put in money on a monthly basis, and then it covers. Not everyone is able to afford this kind of service. Not even people within the middle class sometimes can afford medical aid. So you can understand that medical aid is a luxury that not many who live below the poverty line can be able to access. And that's where in the medical, in the private sector, you find a different mix of contraceptives. There you will find self-administered options of maybe the patch or a NuvaRing, the nice stuff that you can use in the comfort of your own home. But in the public sector, you'll find the stuff that you would need a nurse or a doctor to administer to you. Those are the two differences, and the cost differences, of course. Our nonprofits, our schools, and our youth clubs, these organizations usually provide a supportive service. They usually do the educational programs for young people. They would go out to schools and around, okay, this is where you're at in your reproductive process in your life. This is what you need to do. This is how you start going for family planning and so forth. And then we do have, we have our hotlines, helplines, SMSs, and these desks. What these services do is that in an instant, if, for example, a young girl or a woman is raped, they would contact a hotline or the police. When they get to the police station or the hotline, they would then be referred to the Department of Social Development or maybe the Department of Health so that they can be screened if they have contracted any viruses, or they can be given HIV PrEP medication. And then also, should there be any issues of maybe the person who was raped falling pregnant, it is those departments that then would link them to specific places where they can go to if they want to terminate, want to speak to someone when they will keep their babies, and all of those supportive structures that would come in handy if a young girl is raped and she falls pregnant and she might need contraceptive or maybe information around what to do next in that kind of situation. And then we also have the civil society organizations, the shelters, and the safe houses. These organizations would then be the type of organizations that would be providing assistance post. So, for example, once again, if we go back to a girl that experiences a rape situation, she falls pregnant, she goes into the system where she's assisted by the Department of Social Development, she gets assisted by the Department of Health, and then after that, she might need somebody to counsel her to say, okay, this has happened to you, what are your contraceptive choices that you're going to look at going forward so that we can avoid this situation happening again. So these will be the last part of that chain that I've just explained right now. But what you find in all of these situations is that there's a lack, or there's a need that is not here, that is empathy towards the young person that is trying to understand or trying to find ways of how they can find supportive assistance or access to contraceptives and family planning advice that will be user-friendly for them, or where they will be understood, or where they'll be helped by somebody who understands what they are going through without any judgment, without any discriminatory kind of unnecessary energy towards them, and how we can enhance these services and eliminate the not so good parts, which makes young people not want to go to the public clinics or go to these other areas that I've just mentioned, is that we can try to eliminate the personal interaction spots by making them more digital. By saying this, I mean that in terms of moving around transportation and where some of these centers are stationed, they're usually far off from the communities where the most rural communities are, or where most disadvantaged people live. Like I mentioned earlier on, there's a high adoption rate in terms of cell phone usage. There are so many people constantly on their phones day in, day out. So services and digital platforms that then provide services around education, provide services around online screening and online consultations with a family planning specialist so that you can be able to get recommended the right products. We need these online platforms to be able to provide the full spectrum of the product mix that is available in South Africa, and not just be able to rely on the fact that a certain type of or certain types of contraceptives are available for a certain type of groups and certain types are available for those who are using public clinics. We need to find a way where we can bridge the inequality gap and make sure that everyone is getting equal quality and good enough rights-based services that helps to contribute to them managing their reproductive health each and every day of their lives without, and if you cannot afford. We need more virtual assistance for family planning. For example, like I mentioned, telehealth. We need online menstrual health support platforms. The reason why we need this is because when a girl is experiencing period poverty and she is maybe starting to have a period, she needs to have a place where she can find information. She needs to have a place where she can be able to get supportive information to say, okay, if you don't have a sanitary pad, you don't need to go ask that older who says he's your boyfriend for money, because obviously he's going to ask for sex in exchange. So we need to be able to provide the right information so that we mitigate the risks of young people falling into the traps of unwanted pregnancy, and try to find ways where we can encourage them to inform decisions around their lives, regarding informed decisions on when they want to be pregnant, informed decisions of whether they want to have an abortion or keep the baby, informed decisions just in general about their sexual and reproductive health care. If we can move to the next one. Thank you, Stephanie. So what are the challenges that we're seeing? And it's all good and well to propose all these technological advances that could help us to make sure that we're streamlining services and providing easier access. But the technology challenges is that what works in developed countries might not work. What works in developed countries might not work in developing countries. What works in South Africa might not work in Nigeria. What works in Zambia might not work in Zimbabwe. So we need to find ways of understanding the localized problems of each communities, and to find ways where we can adapt the technologies that we are creating in order to fit the problems that are experienced by the people of each communities. And what we've found is that there's little investment being done towards developing technology infrastructure in rural communities. So you might find that a person who stays in a rural community might not even have access to Wi-Fi, which then limits them or which restricts them from being able to access the technology platform, because the area that they reside in doesn't even have a Wi-Fi tower. So there needs to be some kind of investment into the development of digitizing local communities and townships, so that There's high data costs and connectivity costs. Some people don't have devices. So in the technologies that are being developed, we need to be also aware that we need to find ways to be able to digitally connect with people through means that they are able to reach. For example, if we cannot have, if a person cannot download an app, they need to have an ability to be able to chat or through SMS. So we need to find alternative means on how we can make usage of the digital areas that we have and be able to find ways where we can adapt them so that the person in the most rural community can still be able to engage with the technology platform. Thank you, Stephanie. We can move to the next one. So what should we be focusing on in terms of creating technologies? Because as each and every one of us that are on this call, I would assume that we all have an invested interest in how we can find ways or deliver ways to improve the status of creating accessibility to contraceptives, equal access and quality accessibility to healthcare for all people. We should, if we will be looking at technologies, we should be focusing on issues that will not just look at the income or revenue generation side of things, but also looking at it from a social perspective to help empower the most rural communities and family planning supportive services and contraceptives. So what we should be doing is we should be focusing on technologies that can help us intensify advocacy and policy dialogue around maternal health. An example of what we recently did in South Africa as FemConnect in partnership with about 30 organizations ranging from nonprofits, activists, and many other people. We had a look, we looked at the South African sexual and reproductive health policy. And what we wanted to do is we were asking our government to include menstruators to supporting girls with menstrual, and we'd like to have that as part of our SRHR policy, because when we do that, we eliminate one problem and one barrier that is many young people are falling pregnant and having unwanted pregnancy. Then that gives enough time to focus on the issues around distribution of contraceptives, diverse product mix, the issues around making sure that we still reduce the numbers of HIV and AIDS within as topics that are part of our sexual and reproductive health policies. So we are working on advocacy and also trying to influence policy as an organization as well, because it all starts from policy. And once we get it right with policy, then we can introduce the right steps and the right remedial program African country, specifically in South Africa, technologies that strengthen health systems and that before linking girls to a person that will be willing to assist them with their queries around their family planning, giving them information around, okay, if you use this kind of contraceptive, this is how it's going to react. These are the pros, these are the cons. If you use that kind of information is very critical in order to educate me so that when I make my decision at the end of the day, I make an informed decision that will help me and that I'll be knowledgeable about of what I'm putting inside my body. We need technologies that will provide easy access to community-based information. So organizations that are working within communities often tend to not have a wider reach within their communities, except for the people that they're working in a particular project. So what we are trying to say is that the technologies should be able to amplify the work of those people that are working directly with communities and be able to scale their reach so that the more people get access to contraceptives, the more people get access to sexual and reproductive health information, and all of that then also helps us to reduce the numbers, because at the end of the day, the three key things that we want to see is meeting the unmet needs of family planning, ending maternal deaths, which are largely young people, harmful practices that are done, comprehensive education. So within schools, the Department of Education also needs to step in and provide. We do not have anything that talks about sex education and teaches young people. So it ends up being a conversation between peers, and that's the start of misinformation circulating around circles of young people, and also misinformations that might lead to the wrong decisions being taken. So the Department of Education also needs to step in to say, how do we ensure that we provide adequate information to ensure that we are aligning our curriculum with the policy? And lastly, we need to be able to connect users to service providers in their own convenience, at their own time, in a way that they will be helped discreetly and respectfully without any more time. Thank you so much for listening. Please do get in touch with me. And if you have any questions, I think now I'll open up and hand over to you for questions. Thank you.
Thank you so much for that. We actually have a ton of questions. We will not be able to get to all of them today during this session, but as we always do, we'll send a follow-up email to everybody who registered with responses to the questions that we didn't make it to. So I'd like to focus on the questions I think that are most specific to the actual work that you do, and save some of the like funding questions, the US funding questions, for that follow-up email. So I guess I'll start with how many teenage girls in South Africa have access to computers and cell phones, and can they get education through the mobile app that you have for your program?
So in terms of mobile app usage and computer usage, it's actually gone up since COVID, because before, when schools closed down, a lot of people were forced to migrate to use digital platforms because nobody was allowed to go into the school premises. So I would say the digital adoption from that time up until now would be roughly around 80% at the moment. And these are people that are residing, I would say, semi-rural or peri-urban, semi-rural, and not very rural communities. So the most rural communities, you might find that there will be a person or many people that have access to cell phones, but not a laptop or a PC within their home. So the mobile usage is much more higher than people who have devices in their own home. And that's why an app that is able to reach the person through their mobile phones would be a recommended channel. Apps, WhatsApp, SMS lines, and those kind of things would be very, very recommended for if you want to target peri-urban, semi-rural, and rural communities. But if you want to target from middle class upwards, then you could look at providing a laptop or a computer. So yes, there is accessibility, and how they can access is that throughout our interventions are always digital. So they come to our website or they go to the mobile app, which is available for Android. We intentionally made our mobile app for Android because we know that the type of target audience is not iPhone users, because if you're talking about a rural person that's coming from a rural area, that person might not have an iPhone because it's expensive here in South Africa to buy an iPhone. So we specifically went that route because we want each and every person to be able to get access. And what we did is, for the people who do not have access to go onto our app, we then opened a WhatsApp line to say, you can send us a WhatsApp message, we'll call you back. And what we also did is we partnered up with organizations that work on the ground. One of these organizations is Womandla Foundation, and they have presence in a couple of schools in the Western. So what we work through them, and then they take the word to their communities. So for people that do not have access to the online platform, they would then engage with a person from Womandla, or maybe one of our young people that we have, and we call them FemConnect ambassadors, and they're stationed within community where they are the direct liaison with community members who don't have access to the internet.
That's really interesting. And it actually leads into another question that somebody had, which is, how do you provide access to feminine health resources in more rural areas? So if your organization—
Marianne, are you still there?
Yeah. Yes, I am. Can you hear me? Are you able to hear me?
Sorry, Marianne, I didn't catch that.
Yeah, just on the topic of rural, like reaching rural people, somebody else had a question about reaching people with feminine health resources in more rural areas. So how does that work? If your organization is providing the technology to get people talking about these issues, where do they actually get the resources themselves?
My apologies. I lost you for a moment there. I can hear you now.
I'm going to write the question in the chat. How about that?
Sorry.
There. Can you see the chat?
Let me just go in. Yes, okay. So how we provide feminine hygiene health resources in communities is we work with organizations that work within the rural communities. An example that I just recently mentioned is we would partner up with a nonprofit organization, be a church-based organization or community organization that already is doing the work, and they then becomes our beneficiary organization. We then do the resource mobilization and try to do fundraising for a specific maybe organization. For example, if we do a campaign and we're raising funds to distribute 500 sanitary pads to girls in Langa, we know that that distribution will be done through our beneficiary organization partner, which is Womandla, and we would then give it to them and they do the distribution within the community. So we don't directly work with the organizations, but we enhance and empower the organizations that are already and have been doing the work for years, and we just plug in to amplify the work that they're doing.
That makes a lot of sense. I mean, in a way, that's kind of how this organization works too. Like Population Connection doesn't provide direct health services, but we often put people in touch with organizations that do. So yeah, sometimes having an intermediary can be really effective and useful. Somebody asked about outreach to boys and men. Is that part of the program as well, or is it exclusively to girls and women?
No, actually, it's an interesting area that we are venturing into. One of our youth advocates, or our youth ambassadors, as we call them, is we've got 3 in Cape Town, and 2 of them are males and 1 is female. And one of their roles is to actually engage with the schools and engage with people at community level and do menstrual health drives. And I remember one of the guys saying to me, you know, those little boys at school were laughing at me because they were saying, how can a man touch a pad? And we were all laughing at that conversation. And he said to me, maybe it's time that we start bringing boys to be part of doing these drives and these educational components, and that it's constantly always many male figures in these conversations, and it is time that we actually bring them into the conversations and have them to participate in, so that they are also aware of the issue around period poverty and how they can also be a part of helping.
Yeah, and you know, lest anybody think that this is an issue only in lower income or middle income countries, it is not. I mean, I don't know, it's been many years since I was personally in sex ed, but I know for sure that the men my age in general do not know about these things either. So I think that that is great that you reach out to men and boys, because everybody should know, obviously. Somebody is asking about whether sex education in South African public schools is offered or whether it's mandatory.
No, it's not offered and it's not mandatory. And that is part of the things that we were advocating for in the recent march that we had, because it was something that we mentioned in the need to be looking at it as a Department of Education to incorporate sexual education. What they is life orientation. Life orientation is a subject that teaches you about social stuff, social issues, but it doesn't cover sexual education. And that part has been excluded in the educational curriculum system for quite some time. However, after we had the march, we then were called into a meeting with the Department of Women and Children and People with Disabilities, and they said they were engaging the Department of Health to see how they can bring the issue of sexual education, reproductive health, and also menstrual education into the curriculum at schools as well. But currently it's not happening.
Is there any sort of, this is my own follow-up question, just because of the sort of landscape in the United States, is there any sort of push for abstinence-only education the way that we have here?
There is a push for abstinence a lot, and usually it's also done on a very small scale. So you might find that it's a specific organization that will go into a school and say, we would like to have sessions with grade 8s, and that's actually what we are doing right now. We've partnered up with a primary school. We said to the school we'd like to have sessions with the grade 6s and the grade 8s, which are the last 2 years of primary before heading to a high school. And we want to have sessions with the young people, specifically girls and boys, around the SRHR needs, talking to them about menstruation, talking about them about, you know, issues that they don't usually talk about with elders, but they talk amongst themselves. So it's more, we're trying to have of a more peer-to-peer educational setting where we just chill, talk, laugh about things, and make it comfortable for them to be able to ask questions around sexual education, reproductive health, and menstrual health as well. And usually it's done on a small scale basis by specific organizations who would reach out to schools, but not on a national scale, but as an initiative by the government.
That makes sense. How much influence do women's husbands or partners have on their reproductive decisions in general in South Africa? I'll put that question in the chat in case it didn't come through through audio. Seems like there are more internet issues, which, you know, I think is actually very illustrative of what a lot of this presentation was about. That when you can't rely on a steady internet connection, your options for you know, looking at information on a computer, for example, are quite limited. So it's, you know, easy to see why SMS programs and WhatsApp and whatnot are so popular, because they don't require a strong internet connection. Give her another few seconds to see if she can rejoin, and if not,
I'm here.
Oh, you are here. Okay.
Okay, can you hear me?
Yes.
Yay. Okay, awesome. Yeah, sorry about that. So what I was saying is, you know, the influence of males on women making decisions about their reproductive health is actually quite something, because in South Africa, we currently sitting with a very sad situation of gender-based violence, high numbers in gender-based violence, femicide, and abusive homes. And you might find that sometimes a woman wants to be able, she probably doesn't even want to be pregnant, but because the husband says, I want a child, it limits her from being able to even go to the clinic, because she's being monitored, and there's the abuse at home, and there's a whole lot of a myriad of problem that comes with home situations that are driven by abusive partners and so forth, which is an issue that affects accessibility to family planning services and so forth, because sometimes it's not entirely your decision, but it is the decision of your husband, and that is something that happens behind closed doors. But we need to find ways to be able to encourage those people to come forward and find ways to be able to get help. And that's how technology can also come in, because if he doesn't want me to go visit other people, and if I have an app that can enable me to do my family planning online when he's not home and have it delivered quickly, then I know I can protect myself, even though it's not recommended to do that. But we need to find other ways to work around the societal issues that we are dealing with. And unfortunately, gender-based violence is a key one that is happening, and it's really not nice at all.
Indeed. Okay, well, we just have a couple minutes left, so I want to make sure to ask this question in case you have an answer, which is, has the United States' recent undoing of reproductive rights influenced your work? So is anything that's happening in the United States, I'm assuming this question is probably about the reversal of Roe v. Wade, is that influencing anything for you in the work that you do?
It's not directly influencing anything that we do, but it has influenced the support, funding support towards initiatives such as ours coming from the American government and the American people, because we find that there are developmental organizations that are starting to support innovations around sexual and reproductive health, that are supporting innovations around creating accessibility to abortion facilities and, you know, family planning and those kind of things. So I would say, with the transition that is happening in the United States, it is also it's advantageous for us, for people that are dependent on international grant fundings, in order for us to be able to put this kind of work into place and set it in motion, because locally there aren't much grant funds that, or many funding opportunities that are tailored to support the kind of work that we do.
Right. And actually, a couple of the questions that came in ahead of time over email were about US funding. I might have mentioned that already. So I pulled together a bunch of resources and links, and we'll send that out to everybody after this call, so you can really dig into all of that if you're interested. It's not a pretty picture, I hate to say. But anyway, well, you're getting a lot of comments in the chat about how you're doing courageous work, and you know, thank you so much for the incredible work that you do and for all of the people that you help in your community. And thanks for talking to us today. You know, we're a US-based organization, and so we always really appreciate talking to people in other countries about what the situation is where they live. So this was very informative and appreciated. Looks like Stephanie might want to hop in here.
Thank you.
Just wanted to echo off what you were
so
saying,
much.
Marian. Thank you, Asonele, for being here. It was great to hear more about your work.
Thank you so much. Thank you for the opportunity. And yeah, it was so nice engaging with you guys. Sorry, my internet was acting up, but I appreciate the engagement. And yeah, let's all keep in touch. Let's follow each other on LinkedIn. Send me an email if you want to know any other thing. And thank you so much for having me. I appreciate it.
Thank you. Take care.
Thank you.